Okay, I think maybe we'll get started as people trickle in. It's 12:04, so thank you, Dr. Balter, for joining us here. Welcome to the Medical Grand Rounds at Scarborough Health Network. I'm going to introduce Dr. Balter to our medicine rounds, and I'll let you get started. So Dr. Balter is a professor of medicine at the University of Toronto and staff member at the Division of Respirology at Mount Sinai and UHN. And he's the director of Asthma and COPD Education Clinic at Mount Sinai Hospital. His major interests are in asthma, COPD, and sarcoidosis. And he's also involved in various roles in leadership and peer reviews for the ACCP, American Thoracic Society, European Respiratory Society, and the Canadian Thoracic Society as well. He did his medical school at McGill and internship and residency at Montreal General and clinical research fellowship in pulmonary and critical care medicine at University of Michigan Hospital in Ann Arbor. So you're going to talk to us about treating asthma in a monoclonal world. Dr. Balter, the screen is yours.
Thanks very much. I'm going to assume everyone can see me and see the screen. Shout out if that's not the case. I will try to keep this to about 40-45 minutes maximum, so hopefully we'll have time for education or questions and clarifying anything I said that's controversial, which I hope not to do. My disclosures: I sit on advisory boards for anybody who makes a drug for asthma or COPD. I don't have any financial interest in any pharmaceutical company, and nobody has seen my slides. I just prepare them, so I don't have any influence on what I show you today. It's purely my own fault. So learning objectives: I'm hoping that a general medicine audience at the end of the next 40 minutes or so will be able to separate difficult to control versus severe asthma. The biologics are used for severe asthma, but I want to take you through the asthmatic that you see in the hospital first. I hope I'll leave you with a better understanding of an approach to poorly controlled asthma and talk a little bit about the role for phenotyping and endotyping in severe asthma to help us choose our therapies. And I don't expect you, there are non-respirologists in the group, to start biologic therapy on these patients, but I really hope you'll be more comfortable identifying the patients who will be appropriate candidates for these medications, as they've completely changed the world of severe asthma over the past 10 or 15 years. So the Canadian guidelines, this is the most recent Canadian guidelines. There's more recent international guidelines from this year that I'm not presenting. I'll stick with the Canadian ones, but we arbitrarily define certain criteria to say somebody is well controlled, and they're listed here. So daytime symptoms 2 or fewer times per week, nighttime symptoms less than once weekly. They should have normal physical activity. They should not have exacerbations, and certainly not emergency department visits or absenteeism from work or school. And they shouldn't need very frequent rescue medications. The ones at the bottom are things that most of you don't regularly measure, but the FEV1 or lung function is particularly important. And the reason, unlike COPD, where we want to do spirometry to make the diagnosis, but then we don't care so much what happens to spirometry afterwards, in asthma, we want to normalize lung function as much as possible, because you'll have to fall further to get attacked. So often patients will feel fine if they've been poorly controlled for a long period of time, but their lung function's only 65 or 70% of normal. And we want to keep pushing on that to get them as high as possible. We're not going to talk about sputum eosinophils because it's something that's only available in about 5 or 6 centers all across Canada. We consider somebody poorly controlled if they don't meet 2 or more of the criteria on the screen. And why is that important? Because approximately half of asthma patients fail to achieve control, despite the fact we now have techniques and medications where almost everybody should be controlled. Those are the patients who are more likely to suffer exacerbations. Those are the people who end up in your emergency department. And I'm not sure of the statistics now, but I did some work at Centenary probably 30 years ago now, 25 to 30 years ago now. And the reason that Centenary was picked for this project is that area of Scarborough had the highest emergency room visits for asthma anywhere in Ontario, both in pediatrics and adults together. These are the patients who are more likely to end up in the emergency room and get oral steroids. And one of the things that I've become very sensitized to over the past couple of years is the risk of even short courses of oral corticosteroids. Again, I'm going to take you through that a little bit because it's made me think of using oral steroids a little bit differently. Now, poorly controlled asthma is not severe asthma, and you have to attack the reasons for poor control before characterizing patients as severe asthma. So what are those reasons? When I have somebody sent to me with poorly controlled asthma, this is the list that I go through in my mind, and I hope the one that you'll use in the future. So the first is to confirm the diagnosis, and you go, well, don't be crazy. Somebody's carried a diagnosis of asthma with them for a million years. Of course they have asthma. Why do I have to rethink the diagnosis? Let me give you an example. Everything I show you today are people from my practice. So this is someone from a few years ago, 48-year-old woman who was referred for poorly controlled asthma. She had asthma for about 15 years when I first saw her. She was on inhaled steroids at standard doses and was getting salbutamol for breakthrough. Her physician stepped her up to an ICS-LABA combination to treat her asthma as guidelines changed. And she was sent here with 2 years of worsening dyspnea, classic triggers of stress and exercise, which is quite typical for asthma, but she didn't always respond to salbutamol. Over the preceding 2 years, she had had 4 courses of prednisone, each one leading to a dramatic improvement in her symptoms, only to have them slowly creep up again. Her past history was fairly unremarkable. She had had a nasal polypectomy for her allergic nasal polyposis. She was a non-smoker, and when I examined her, her chest was clear and her heart was normal. Her chest x-ray was normal. Her eosinophils were elevated, the upper limit of normal of 450, and her IgE was slightly elevated as well, going with a diagnosis of asthma or of allergies. I did spirometry, and she had mild airflow limitation with an FEV1 FVC ratio of 71%. She only improved by 8% post-bronchodilator. As a reminder, you have to improve your FEV1 by 12% or higher to say that you have reversible obstruction. So I was asked to arrange for a methacholine challenge test to measure whether she had bronchial hyperactivity consistent with asthma. But as I looked at her flow volume loop that I had done in the office, just for those of you who don't look at these, this would be an inspiratory loop. As a matter of fact, I'll go forward for a second so you'll see what a normal inspiratory loop looks like and a normal expiratory loop. And when we have somebody with asthma, we see a concavity or convexity inwards of the expiratory loop, which tells me that there's obstruction. But if you go look at this person's loop, the expiratory loop is quite flattened, and the inspiratory loop is quite flattened as well. This is not what we generally see in asthma, and it's suggestive of a fixed obstruction somewhere in the airways. So I took her to the bronchoscopy suite, and this is what a normal trachea would look like. It's actually her trachea, and you can see over here the carina and normal airways. But if you go up higher, there's marked narrowing of the trachea. And she had subglottic stenosis or tracheal stenosis that subsequently was dilated by our thoracic surgeons, curing her quote unquote asthma. So for years, this woman had been treated for asthma, and she got better with prednisone because that would transiently reduce some airway edema that happened with a cold. And she never had asthma, and she suffered for 15 years with a disease that would have been easily treatable had it been diagnosed earlier by doing spirometry. So take-home message number 1 is confirm the diagnosis with spirometry pre and post bronchodilator. Very cheap, very simple, very safe test. The second thing that I do when I have somebody in front of me is I check their adherence. To give you some idea, these are some statistics from the Asthma Society in Canada. Up to 1 in 3 asthma patients have no intention of filling their maintenance inhaled corticosteroid prescription if they've even filled the first one or completed it. 8% never even fill the prescription. Even patients ending up in the emergency department who are coming there because they're very bad don't finish their course, their 5-day course of oral corticosteroids. They take 2 days, they feel better, they save it in case their doctor's out of town for the future. So adherence is an enormous problem, and probably a third of asthmatics who aren't controlled purely are not controlled because of lack of adherence to therapy. If nothing else, on a slow office day, I have patients show me how they use their inhalers. I'm sure my colleagues in the audience can give very similar stories of things that they've seen people do. I've had people spray meter dose inhalers onto a spoon and ingest it. I've had patients spray directly onto their chest because I told them the value of an inhaled medication is it goes right to their lungs, so they think they'll bypass the middleman. And I can share the rest of the 40 minutes just telling you things that I've seen people do incorrectly. So at the very least, observe your patients taking their inhaled medication. When my patients ask me what asthma is, I tell them that they should think of a fire burning in the airways. And the goal of asthma therapy is to keep the fire from burning under control. The embers are always smoldering, and inhaled steroids keep the fire from burning out of control. But I explained to them that they would never think of putting out a fire by pouring gasoline on it, but that's what they do. They let the cats that they're sensitized to into the bedroom. They don't do dust avoidance measures. About 16% of my asthmatics smoke, which is probably the worst thing you can do for asthma, and some have occupational sensitizers. So you have to always ask about those things before you attribute their asthma as being severe. I want to take a second to talk about cigarette smoke because it's a two-pronged sword, if you will. We know that not every young smoker develops progressive loss of lung function. Probably the age of 40, only about 15% of smokers have an accelerated decline in lung function. But if you have asthma, you're guaranteed to have an accelerated decline in FEV1. Now, as I mentioned, patients with asthma, the primary therapy is inhaled corticosteroids, but cigarette smoke changes the airways. Asthmatic airways are mostly eosinophilic in nature, and inhaled steroids and oral steroids are terrific at reducing eosinophilic inflammation. The problem with cigarette smoke is it changes that eosinophilic milieu to a neutrophilic milieu, which is relatively resistant to inhaled corticosteroids. So in asthma, there's a dual reason to get patients to stop smoking. These are the other things that I go through. I don't want to take a lot of time. This one's obvious. Anything that inflames the upper airways will inflame the lower airways. It's a continuum, the mucosa. So you always have to treat the nose and the sinuses. Reflux, the mechanism is less well understood. It seems that alkaline reflux can also worsen asthma. So fundoplication helps asthma, whereas PPIs might reduce cough, but don't really improve lung function. About 10% of asthmatics are sensitive to NSAIDs, so they can greatly worsen their asthma. Beta blockers, the beta-1 specific agents, are less likely, but not impossible to worsen asthma. Obesity is something we're increasingly looking for, particularly in women. Obesity in women seems to decrease efficacy of inhaled corticosteroids at a cellular level. And there's good evidence now showing that gastric bypass surgery for morbidly obese people obviously decreases dyspnea, as anybody who loses weight will have less dyspnea, but it decreases bronchial hyperactivity. The mechanism isn't completely understood, seems to be related partially to the release of adenopectin, which is a hormone in fat tissue in women. The things that my specialty colleagues see are allergic bronchopulmonary aspergillosis and eosinophilic granulomatous polyangiitis, which you probably during your training you learned at Strauss vasculitis. These are rare complications of asthma that I'm not going to talk about to a general medicine audience today. So let's get back to random asthma factoids, if you will. Once you go through those reasons for poor control and treat the ones that you can treat, if patients still don't meet criteria for asthma control, they are considered to have severe disease. And that only makes up 5 to 10% of asthmatics. But those 5 to 10% of asthmatics are responsible for more than 50% of all direct asthma-related costs. They have greater effects on the quality of life scores, more likely to miss time from work and school, and obviously much more likely to get oral corticosteroids. So the definition of severe asthma is when asthma is confirmed, comorbidities addressed, and people still are in control despite high doses of inhaled corticosteroids and at least one other drug, usually a long-acting beta agonist, occasionally a long-acting anticholinergic, or patients chronically on oral steroids. As mentioned, severe asthma are the people, or patients with severe asthma are the people who end up with exacerbations and in your hospital, have poor quality of life, have tremendous side effects from oral corticosteroid use, which I'm going to get back to in a second, are actually at increased risk of mortality, which thankfully in Canada is relatively low. About 200 asthmatics die in Canada every year. The sad part is almost every one of those is avoidable. And they're the ones who cause higher healthcare costs compared to well-controlled disease. So before we talk about therapies and biologic therapies in particular, I want to change focus for a second and talk about oral corticosteroid side effects. In Canada, thankfully, there's not a lot of people on chronic oral corticosteroids with asthma. I did my training, as you heard, in the US, where inhaled corticosteroids are ridiculously expensive. So patients just refuse to take their inhaled corticosteroids, and were happy to take low doses of oral corticosteroids forever because they were cheap. So up to 22% of patients with severe asthma in the States are on chronic oral corticosteroids, much higher in Europe. We all know some of the side effects of oral corticosteroids. I think the one that we're most familiar with is osteoporosis, but it causes myopathies. A patient I just saw just prior to giving rounds is somebody with EGPA who has been on oral steroids forever and has a proximal myopathy, which is causing dyspnea with exertion. They cause psychiatric issues with mood disturbances, even psychosis. They cause cataracts and glaucoma. They increase risk of infection. Of course, they contribute towards diabetes. They cause bruising of the skin, which you'll see in your elderly patients, even on short courses of oral corticosteroids. So they're not candy. Now, this is a different way of thinking about oral corticosteroids. This was a survey done of allergists and asthma and respirologists who had at least 10 severe asthma patients in their practice. 95% of the patients had been prescribed oral corticosteroids in the past. 3/4 received short courses, an average of 2.4 times per year. 1/4 were actually on regular oral corticosteroids with mean daily dose of just under 12 milligrams. Now, if the average person getting a burst is on for 7 days, most patients get 5 to 7 days, and the dose is 50 milligrams, which is the most common dose given in the emergency department. If you're getting just 2 courses of oral corticosteroids in a year, that is 700 milligrams of prednisone. Why do I mention that? This is a very good study coming out of a Danish registry with a high number of patients, over 30,000 oral corticosteroid users with 4 times as many non-users. And they broke the annual dose down to no use, low dose less than 500, or medium dose 500. Remember, I just said the typical asthmatic gets 700 milligrams in a year, or over 2,000. And what you can greatly see is mortality goes up quite significantly when you're over 500 milligrams, much higher when you're over 2,000 milligrams. But look on the right, and you can see that as you get to medium uses of oral prednisone, a much higher risk of osteoporosis, a much higher risk of diabetes, a much higher risk of ischemic heart disease, a much higher risk of peptic ulcer disease, and a higher risk of cataracts. And so even though we, myself included, indiscriminately give oral corticosteroids because we don't have other treatments for severe asthma, we're doing tremendous harm even if patients are on 2 courses of oral corticosteroids per year. And that's the real reason why I want you to identify these patients to see who would be candidates for biologic therapy, because you're not only going to greatly improve their quality of life, you're going to greatly decrease their morbidity from the harmful effects of oral corticosteroids going forward. To determine who gets biologic therapy, we start to use phenotypes. Now, we don't have a lot of phenotypes at this point for asthma. I'll go through a few of them with you. They overlap. A phenotype could be as simple as saying a banana and a lemon are both yellow, so they share the yellow phenotypes, even though you know that lemons and bananas don't have very much in common. So phenotypes can be helpful observational things that may not have physiologic or biologic relevance, whereas endotypes would be things like aspirin-sensitive asthma or eosinophil-sensitive asthma, where you have a specific biological mechanism explaining the outcome. So endotypes are preferred, but we have minimal endotypes, so we tend to use asthma phenotypes. This is how birds see the world. It's how respirologists see asthmatics, where there's various cytokines and mediators swimming around in the airways, and we're not quite sure which ones are important. Some might be epiphenomenon released because of another mechanism. So the way we determine whether a cytokine or a mediator is important is only by discovering things to block a specific mediator and cytokine. And then if that improves the disease, we determine that that's an important component to their illness. Probably the first specific blocker that we had, or the first designer drug that we had for asthma, were leukotriene receptor antagonists that came out in about 1996 in Canada. Didn't play a major role in improving most asthmatics, but we were able to identify certain patients who would benefit from that. We've become more specific and more exact in the mediators that we block at the present time, and that's what I'm going to take you through over the next few slides. So this is a good review article out of the Beth Israel Hospital in Boston, where we look at inflammation in the airways as being divided into two parts. T2 high inflammation are what we've targeted up to very, very recently. We had nothing to target non-T2 high inflammation. We do now, and I'll get to that later on. So in order, the first thing that we had access to were things that block IgE. You might know omalizumab or Xolair as an IgE blocker, and that's been around for well over 10 years. The next kids on the block were things that block IL-5. These were our various mepolizumab, benralizumab, and reslizumab, all blocked IL-5 or IL-5 receptors. More recently, we've had IL-4 and IL-13 blockers with dupilumab, and the most recent release has been things blocking thymocyte stromolymphopoietin or TSLP, which I'll say in the interest of time, blocking higher up at the epithelial level, and this is tezepelumab. And I'll take you through very little bit of information on each one to give you a feel for how they work and what they've accomplished. So as I said, the first one out was omalizumab, and these were the indications for it. It was in adults or pediatric patients over the age of 6. And the criteria are they had to have a positive skin test to a perennial aeroallergen. They had to be on high doses of inhaled corticosteroids. But the limiting factor was they had to have an IgE in the 30 to 700 international units per mil range. This isn't very high. Most of my patients with atopy have IgEs in the many hundreds or thousands. So as a result, many of these patients could not be given omalizumab in Canada, although other countries don't have this criteria. And omalizumab has been shown to work in patients with IgEs in the many thousands. We don't have to block every single IgE molecule. The concern was because we had a weight-based and IgE-based dose for IgE, that is, you got higher to 700, the amount of the injection would just be too large to give. Other countries have clearly shown that you don't have to give such a high dose, and the drug is very effective. But I'm limited in Canada with using this drug because of the relatively narrow IgE range for which it's approved. It's been recognized that the eosinophilic phenotype in severe asthma represents over 80% of patients who have severe disease. Other things worsen asthma, such as nasal polyps, oral steroid dependency. Adult asthma is more likely to be a T2 high disease. All of these things are seen more frequently in the eosinophilic phenotype. Elevated eosinophil counts have been associated with increased asthma severity, higher risk of exacerbations, and lower lung function, as you can see from this slide. This is as you go down on the y-axis, this is an increase in eosinophil counts, and you can see the frequency of exacerbations ties very closely to higher eosinophil counts. And you can see on the other side, again, as eosinophil counts go up, overall asthma control worsens quite significantly. So for many years, it was determined that a very good target for treating asthma would be something to block eosinophils. And that's really where our 3 IL-5 inhibitors come in. As I mentioned before, benralizumab, mepolizumab, and restylizumab. Their criteria are all very similar in that they have to have at least 2 patients have to have at least 2 courses of oral corticosteroids. I'm unhappy about this because it means I have to unnecessarily expose people to a second oral course of oral corticosteroids to get approval, but I'm sort of stuck at doing that. There's no cutoff for benralizumab, but quite frankly, I would not use any of these with eosinophil counts of less than 150, and I'm more likely to see success if the eosinophil counts are 300 or higher. And similar to omalizumab, patients have to be on high doses of inhaled corticosteroids with at least 1 other controller medication before meeting criteria to get these medications. Just to give you a little bit of information from the registration trials, again, I don't want to spend a lot of time, but you can see here in the DREAM and MENSA study, I have no idea where these names come from, but both of them, various doses of mepolizumab, either given intravenously or subcutaneously, led to a dramatic decrease in clinically significant exacerbations as compared to people on standard therapy getting placebo injections. So these were the registration trials for mepolizumab. Similarly, in the benralizumab trial, it's been shown, not surprisingly, that patients who benefit the most have the highest eosinophil counts, and that has the greatest effect on reducing exacerbations and improving lung function. The more frequent exacerbators, the patients chronically on oral corticosteroids, or patients with a history of nasal polyposis, all respond better to IL-5 inhibition. And subsequent to that, IL-4 and IL-13 inhibitors came out that work on different pathways, again, targeting T2 high inflammation, and dupilumab is the drug that has been studied most effectively blocking these mediators or cytokines. Similarly, dupilumab is very effective for treating atopic dermatitis and nasal polyposis. This is a study, again, from the dose-finding trials of dupilumab, clearly showing that patients who were given active medication had a marked decrease in the exacerbation rates and severe exacerbation rates as compared to placebo. So if we're going to make reduction in oral corticosteroid dependency the holy grail of treating patients with biologics, how do our current biologics stack up? So I'm going to summarize a lot of information with just a couple of slides. In fairness, omalizumab doesn't have a lot of good steroid-sparing data, but they did not require that as part of their registration trials. So their endpoints for their trials were decrease in exacerbations, which they've been very effective in reducing, but fewer patients were on oral corticosteroids and no prospective data was looked at for these patients. So everything depends on registries. So something called the Experience Registry showed that fewer patients were on oral corticosteroids after 12 or 24 months as compared to their baseline. The APEX study showed that they reduced oral corticosteroids from just under 7 milligrams to just over 4 milligrams per year. So statistically significant, but again, in fairness, only retrospective data is available because they were not required to show steroid sparing effects. So let's look at our IL-5 inhibitors. You can see here that baseline oral corticosteroid usage fell very significantly with patients who are on mepolizumab as compared to placebo. Looking at it a different way, and you'll say, wow, that's good placebo. 8% of patients were able to get off oral corticosteroids completely. This is a very important point that you should look at in any asthma study. There's a lot of single arm asthma studies out there from many years ago purporting to show all kinds of beneficial effects with no placebo group. There's an enormous placebo effect to treating asthma, and it's not all placebo. Patients in clinical trials all of a sudden are observed and are given free medication, so they're more likely to take inhaled steroids where they weren't taking them before. They get a lot of TLC. They're seen every month or 2 months by clinical trial nurses, very interested in their care. All of that goes towards helping treat asthma. The majority of people sent to me with poorly controlled asthma who I'm told can't get off oral corticosteroids, I get them off in no time at all by getting them to adhere to therapy, using drugs correctly, and working on a couple of comorbidities. So this isn't surprising. Nonetheless, despite the fact that more patients with mepolizumab were off oral steroids completely or were on much lower doses of oral steroids, the asthma exacerbation rate looked at annually fell by 32%. So very, very effective therapy. The benralizumab trials show the same thing, more powerful placebo. 19% of patients got off oral steroids. Again, many of these patients were from Eastern Europe where they weren't taking regular medications and now were put on regular therapy, so they were able to get off oral steroids. But despite this dramatic reduction in oral corticosteroid use, patients on benralizumab had a 70% reduction in asthma exacerbations. And finally, dupilumab showed the same thing, 29% of placebo patients off oral corticosteroids, but a 59% reduction in annual exacerbation rates of patients on dupilumab as compared to placebo, despite the fact that they were on much lower doses or no oral corticosteroids at all by the end of the trial. So I think you can see here that all of our current biologics have dramatic effects in terms of reducing oral corticosteroid usage and decreasing exacerbations. So you want to identify the patients who would benefit from this drug. So I'll do a temporary summary at this point to say that it's increasingly clear that even intermittent bursts of oral corticosteroids are harmful, particularly on the bone and adrenal gland. Many patients out there getting oral corticosteroids would benefit from current biologics, but they're not recognized. So this is what I want you to take home with you, is to look for these patients in your practices or in the emergency room. It's equally clear that patients up to very recently who did not have a T2 helper phenotype or T2 high phenotype did not benefit from our current biologics. So what options did we have for that non-T2 high phenotype? Well, the first thing we had was azithromycin. You probably know that azithromycin has anti-inflammatory aside from antibacterial effects and has been used for quite some time in various cases of bronchiectasis or cystic fibrosis to decrease mucus hypersecretion and decrease exacerbations. This was a study from Peter Gibson in New Zealand looking at non-smoking asthmatics who were on high-dose ICS/LABA and not controlled and were randomized to get azithromycin 500 milligrams thrice weekly versus placebo, and they were followed for 48 weeks. They defined severe exacerbations as a need for oral corticosteroid use or hospitalization. They defined a moderate exacerbation as having an emergency department visit, but no oral corticosteroid use, which was shocking to me because I have never seen an asthmatic go to the emergency room and not get oral corticosteroids, but maybe things are done differently in New Zealand, or if they had antibiotics or increases in ICS. They did measure peripheral eosinophils and looked at that in their final tally. what you can clearly see is that the patients on azithromycin as compared to placebo had a marked decrease in exacerbations. Patients had a lower risk of annualized asthma exacerbations, and they had much less in the way of antibiotics for flares of their disease. I would have expected most of this benefit to have occurred in patients with non-eosinophilic inflammation, but they actually showed a benefit in patients with both eosinophilic asthma and non-eosinophilic asthma, and patients who were on any dose of inhaled corticosteroid or frequent versus mild exacerbators. There was more diarrhea in the patients on azithromycin, but no QT prolongation, which is a concern with using this as an azolide rather than a macrolide. I would have greater concerns with a macrolide, but that was reassuring. So all of a sudden we had an option to give to patients who had non-T2 high inflammation. Even though this worked in T2 high inflammation, I would never think of using it in those patients. I would always go to something to block eosinophils first or exhaled nitric oxide. So do we have some novel targeted therapies now for asthma? And the answer is yes. So I mentioned before, and by the way, any of you who want a really good review article on biologics and asthma or have difficulty sleeping and want a sleeping aid, I would look to this article by Guy Broussel and Kopelman, published in New England Journal of Medicine in January of 2022, which is a very good review of the science up to that point. So we talked about things that block inflammation more distally. I talked about omalizumab. I talked about IL-5 inhibitors and restylizumab and mepolizumab. I talked about IL-5 receptor antagonists with benralizumab, and I talked about IL-4 and 13 inhibitors with dupilumab. But as I mentioned, I have nothing to treat T2 low asthma. We now have a drug, tezepelumab, or a TSLP inhibitor that I alluded to before, that works at the epithelial level and works on both of these pathways. So the airway epithelium, not surprisingly, is the point of contact with various triggers, be they allergens or viruses or secondhand smoke or pollutants, physical stimuli such as cooling of the airways with exercise, and are involved both in airway inflammation and airway hyperresponsiveness. Whenever you have an exposure to any of these stimuli, thymocyte stromal-lymphopoietin or TSLP is released, and it leads to worsening airway inflammation, but also leads to airway hyperresponsiveness. Airway hyperresponsiveness is more closely linked to symptoms such as dyspnea, whereas inflammation is more closely linked to exacerbations and cough. This is one of the registration trials for tezepelumab, showing a marked reduction in annualized asthma exacerbation rate in all comers, patients with T2 high or T2 low asthma, and also a decrease in annualized asthma exacerbation rate leading to hospitalization in active drug as compared to placebo. Tezepelumab blocks all the T2 high mediators in that it reduces eosinophil count, it reduces exhaled nitric oxide, which is more related to IL-13 release, and it reduces total serum IgE. It does not, in the clinical trials in patients with oral corticosteroid dependency, reduce oral corticosteroid dependency. So it reduces the need for oral corticosteroids by decreasing exacerbations. But in the initial trials, did not get patients off oral corticosteroids any more than placebo. Although in fairness, in that trial, the placebo success rate to get patients off oral corticosteroids was enormous. There's another trial going on now looking at specifically reducing oral corticosteroid dependency in patients with asthma. So some of the questions when I put patients on on biologic therapy is, if someone's not doing well, can we switch between therapies? There's a bit of evidence suggesting yes, but not a lot of good studies. Can we stop therapy? Because that's the most common question that I get from my patients. They're doing tremendous and they go, I've stopped my inhaled drugs, which I'm against, I'll get back to. And now can I stop my biologic therapy? And I'll show you why I'm not ready to accept that yet. Safety in pregnancy, certainly for omalizumab, it's been shown to be safe in pregnancy. The other medications haven't been out long enough, so it's a big question for me what to do with these drugs if my patient's doing well on them becomes pregnant. Of course, eosinophils are not only bad things in asthma, they're good things in protecting against parasitic infections. So when I have patients from endemic countries with high parasite loads and very high eosinophil counts, at the very least, I send off strongyloides serology. There's a few case reports of herpes zoster in patients treated with mepolizumab. I don't routinely give patients Shingrix before starting on them, but I do mention that they might want to get that and to discuss with their family doctor before starting biologics. There's not a lot of information to tell me whether I can stop a biologic in someone doing well. As mentioned, my patients frequently will stop their inhaled medication, and I strongly discourage this for two reasons. One, most of the biologics don't treat bronchial hyperactivity very much. So I want to treat the muscle spasm component of their illness, which will decrease symptoms. So inhaled steroids target a different pathway than the biologics, and I encourage them to at least continue on a low dose of inhaled corticosteroids. My other reason is a practical reason, because I'm concerned that patients who are on biologics who stop their inhaled medications, insurance companies will stop paying for the medication because they'll say, oh, they need a biologic because they're not adherent with therapy. So I have to prove that my patients are still on inhaled medication so they don't lose funding. So to address the question about whether or not patients can stop biologics, I'm going to show you one study over here where patients who are on long-term therapy, these were patients on more than a year of mepolizumab and doing very well, could switch. Some could stay on open label mepolizumab, but they can also stop taking their medication, and they were followed off of mepolizumab after a couple of years of therapy. We won't look at the breakdown of the patients. They're the same as in all asthma trial, usually people in their late 50s, more women than men, etc. What you can see here, if you look at the patients who stopped their medication, is very rapidly their blood eosinophil count began to increase. Tied with that was an increase in symptoms, and shortly after that, an increased risk of exacerbations. This would suggest to me that biologics are forever. Is that necessarily true? No. One of my biologic gurus that I frequently speak to is Michael Wexler, who's a pulmonologist at the National Jewish Hospital in Denver. And I've asked him this question. He says that they're gingerly taking a few patients who have been controlled for years on biologics off with close monitoring, and they've had some people who were able to get off biologics and maintain control. Unfortunately, there's no clear factors identifying those people. Perhaps we'll learn more about that as we go further. So I want to end with one of the dilemmas that I have as a respirologist. There's something called the International Severe Asthma Registry, and this random survey was sent out to 70 members of this severe asthma registry, where they were given 7 case scenarios, and they were saying, what drug would you use? I should say tezepelumab wasn't available when this survey was done. So they had an anti-IgE inhibitor. They had 3 anti-IL-5 inhibitors, and they had an IL-4 and IL-15 inhibitor. So all of the drugs that we've had until recently in Canada. And you can see it's a complete crapshoot. You could take a dart and throw it at this board. There is no agreement of what biologics should be used. So we need better ways of identifying patients who would benefit from specific drugs, and we're not there yet. And that really highlights the importance of continued phenotyping. As part of that Brussels article that I alluded to and I recommended to read to go over some of the stuff I'm saying was a very good summary slide that has been changed a little bit so I can appropriately summarize what I talked about today. When I have a poorly controlled asthmatic sent to me, I first confirm that they have asthma. I make sure they're taking their inhaled corticosteroid and using a proper technique. I try to treat reversible factors such as allergen exposures, occupational sensitizers, or smoking, and I treat coexisting conditions, particularly sinus disease. If they're still poorly controlled, despite that, they have difficult asthma, and this is a way of looking about what to do with those patients. If they have very low eosinophils, they would not benefit from IL-5 inhibition. If they have high nitric oxide, they might benefit from an IL-4 receptor antagonist, IL-4, IL-13, like dupilumab, or they might benefit from an anti-TSLP. If they have low nitric oxide, if they're allergic, they would benefit from an anti-IgE. If they're not allergic and they have low eosinophils and low FeNO, my only drug are anti-TSLP inhibitors. If they have high blood eosinophils, then all of a sudden I have many drugs to choose from: anti-IgE, anti-IL-4, anti-IL-5, anti-TSLP. And the questions about which one to pick really depend more on certain other phenotypes they have. If they have nasal polyposis, I'm more likely to give them mepolizumab or dupilumab. If they have bad atopic dermatitis, I'm more likely to give them dupilumab. If they have high FeNO, I'm more likely to give them dupilumab, etc. As mentioned, we need better phenotypes so that we can narrow down our choices, but I want to leave you with these thoughts. Difficult to control asthma is due to treatable factors. You have to address all of those things before saying that somebody has severe asthma. It's only when they remain poorly controlled, despite correcting the treatable factors, and they remain on high-dose inhaled steroids and a second drug and still have symptoms, that they have severe asthma. I don't think there's any question that biologic therapy is a tremendous boon to these patients. I cannot tell you how quickly and gratefully patients respond to the biologic therapies. Picking which drug to give for which patient is going to require better phenotyping and better endotyping, which I think we'll get to. And at this point, biologic therapy may be forever. So I'm going to sum up, or I'm going to conclude the formal portion of my talk with about 12 minutes left for questions. I want to thank you for taking time out from your lunch hour to listen to me drone on. I'm going to stop sharing my screen. Please feel free to unmute yourself to ask me questions or put things in the chat. Thanks very much for your attention.
Thanks very much, Dr. Balter. So we'll take questions, and yeah, you could type it in or you could unmute yourself and go ahead and ask away. While well, the physicians are typing or thinking, I have one question. So, undoubtedly, this has been a game changer in terms of the quality of life and reducing exacerbation rates in patients. Definitely, you've shown it. You've shown us through the trials that you have shared with us. Have you seen any provincial data or Canada-wide data in terms of actual reduction in hospital admissions and exacerbations due to asthma at that level, provincial level?
I have not. So it's a really good question. I would think the companies might have access to that through CIHI data, but that's not something that I can get access to. As you know, as I'm sure you see in your own practice, hospitalizations for asthma in our province for people who can afford medications are not very high. Emergency department visits are very high. I'm more interested in stopping emerge visits and oral corticosteroids. So it would be wonderful to see fewer hospitalizations, but really the things that I look at in my practice are, have I decreased their oral steroid use? Have I decreased their exacerbation rates? And I have to say, there are patients who have dramatic responses, as I said, after 1 or 2 doses, particularly the IL-5 inhibitors, which seem to work faster than omalizumab and some of our older therapies. But I have other patients who I think would be the poster children for being on biologics and don't respond at all. And I'm trying to figure out why that is. I'm not, and it's a subject of great interest to researchers, obviously, but that to me is a bigger source of consternation, where I have somebody who I think this drug's going to change your life and nothing happens.
Yeah.
So I don't know if you have similar experiences, but it's something that I find quite perplexing.
Sure. it's a related question, but again, guys, if you have questions, please type in or feel free to ask. The trials are done with pure asthmatics, and you exclude the COPD patients. Can you speak briefly about whether or not there's any role of this in COPDers? And secondly, what about the ACOS patients who've been labeled COPD, but then you discover there's a huge reversibility? Those may be the more real world patients that we see. So what are your comments about that?
Yeah, sure. Ask me the hard questions. So, 20 years ago, when I knew everything, I could separate asthma from COPD. As I get older, I'm not sure I understand what asthma or COPD is. I mean, we all understand that a 20-year-old comes in with tremendous wheezing and chest tightness when he visits his grandmother, who has 6 cats and last dusted in 1943, likely has asthma. And we all agree that somebody who had no respiratory symptoms and has smoked a pack of cigarettes a day for 40 years and presents with airway narrowing has COPD. But as you alluded to, there's people who have tremendous overlap. And the problem is, for a while, we had this asthma COPD overlap. And now people are moving away from that because nobody could define it. I went to a seminar at the European Respiratory Society when I was last unafraid to go into public before COVID, and saw 6 different definitions of asthma COPD overlap. So I'm stuck with clinical criteria, as you correctly pointed out. The studies looking at anti-IL-5 inhibitors, and that's the only one that I'm aware of studies being done. I know right now they're doing a TSLP inhibitor in COPD, but up to this point, I'm only aware of anti-IL-5 inhibitors in COPD with both mepolizumab and benralizumab, for the most part, have been negative. There have been a couple of people who've responded dramatically, and they're now they're doing post-hoc analysis. They're doing meta-analysis to say, yes, these drugs have a role. But at this point, I think in pure COPD, no. However, you bring up patients who have COPD and have tremendous reversibility and have elevated eosinophils. I have tried those patients on IL-5 inhibitors, and I have to say I've had a couple who've responded, but overall my experience has been negative. And I don't know why, because whether they have asthma or COPD, they meet all the criteria, the people who went into the clinical trials, and I would think they have a tremendous benefit. But I've been disappointed in how few have actually had a benefit. Now we're talking about, I put maybe 15 people on it, so it's not like an experience of hundreds of my COPD patients that I've tried on this. I've had about 3 that have had dramatic improvements, a few meh, and at least half with no response whatsoever.
Okay, great, thanks. Anyone else have questions other than me?
Wow, I'm never that clear.
Oh, these guys might be shy. Come on, guys. Any questions?
Oh, half of them know me. They know they don't have to be shy. Thank you, Dr. Bierbreyer.
Maybe another quick question while we wait for others to chime in if possible. You mentioned the role of these medications, some of the IL-5 antagonists in patients with nasal polyposis. Do we need an ENT consult for diagnosis of nasal polyposis?
I mean, yes, to adequately diagnose. See, what I've learned from, I work very closely with Ian Witt. I work with a number of people, but Ian Witterick and I really share a lot of very difficult asthmatic patients and with chronic rhinosinusitis with nasal polyposis. And Ian has taught me a lot about nasal polyps. He's taught me that CT scans that report nasal polyps usually aren't accurate. That's not the way to do it. If you have a nasal speculum in your office, you can easily see nasal polyps. So you can see that certainly grade 2, 3, and 4 polyps. You may miss some of the grade 1 polyps, but you'll certainly see patients very easily with grade 2, 3, and 4 polyps. So no, you don't need an ENT physician to make that diagnosis. I like working carefully with them. because the question is, would they benefit from surgery? Often surgery might, especially for the patients with grade 3 and grade 4 polyps, I find usually they have to have at least one surgery first. If they relapse in 10 years, I might send them for another surgery. If they relapse 2 months later, I'm looking at a biologic rather than more surgery. So I work quite carefully with the ENT people, but I can make the diagnosis of nasal polyposis on my own in most cases.
Thank you for sharing that. I have one last question if no one else asks. And we'll let Dr. Balter go. Last question. It's a two-pronged question. Is COVID over? Second part is it safe to do office spirometries in a hospital clinic?
So considering I think Ron DeSantis is declaring his candidacy for US presidency today, he's told me that COVID is over, as has Donald Trump. I don't think COVID is over. But so a separate question. I've been doing office spirometry since August of 2020. So I changed. I see a few people out here a couple of people out there who were fellows with me on the thing. And, you know, I've had office spirometry for over 30 years here. I used to have a permanent filter with a disposable mouthpiece. When COVID came along, I bought disposable turbines, which are very expensive. They cost almost as much as I get paid for the spirometry. So it's not terribly cost effective. If you're looking to retire doing it that way, it's a very bad retirement plan. But I've been doing spirometry where until recently I wore a mask and a shield. I've stopped wearing a shield now. I'm just wearing a mask when I do the procedures. I'm less worried about COVID. Does it still exist? Yes. We do the screening questions if patients have symptoms. No, we don't do spirometry. If they've recently had a cold, we don't do spirometry. But I've been doing spirometry for 3 years.
Thank you for sharing that, Dr. Balter. And Dr. Balter, thank you very much again for speaking to us. Hopefully, you've illuminated to the rest of our colleagues why us respirologists are so enamored and obsessed with the eosinophils, and we'll keep on documenting them. But again, thank you very much.
All right, thanks for having me.
Clinical and very appropriate and very illuminating topic. Thank you so much again.
Thanks. Bye, all.
All right. Good night.